Hello, everyone, and welcome to West Virginia Gut Club. I am Justin Kupek, an associate professor of gastroenterology and hepatology at WVU. This is the first of what we hope will be a recurring event aimed at improving GI care throughout the state and bringing GI providers together. Please make sure that you are on mute for the entirety of the presentation. Any questions you may have should be typed into the chat, and these will be addressed by our moderators. To claim CME credit, I will need the information denoted in the chat sent to me via email. I will now turn over the program to our moderators, Dr. Boone and Dr. Singh.
Welcome, everyone. This session will be moderated by me and Dr. Boone. Boone, our panelist and speakers, is Dr. Thakkar. He's professor and director, advanced therapeutic endoscopy. Dr. Markovich is an assistant professor in the Department of Radiology. Dr. Carl Schmidt is the professor and chief division of surgical oncology. And Dr. Patadji is the assistant professor, Department of Pathology. Brian will start with our first presentation.
All right, thank you, Shailendra. So Dr. Markovich and I are going to go ahead and get us started, and we wanted to just start out with kind of a general overview for our differential for pancreatic cyst, and kind of agree on some common terminology and discussion about some of the clinical presentations of these cysts, as a lot of times that frames our workup and kind of how we're thinking about these from the beginning. So just to start out with a differential that's not meant to be, extensive, but at least an overview of some of the more common things that we're thinking about. We generally will break these up into benign, pre-malignant, and malignant cystic lesions. And in the benign category, the most common thing we tend to see are pancreatitis-associated cysts, and we'll talk more about those later in the talk. Also serous cyst adenomas and lymphoepithelial cyst. And then pre-malignant cysts include mucinous cysts like an MCN or mucinous cystic neoplasm, as well as intraductal papillary mucinous neoplasm or IPMNs. And then when we think about malignant cyst, that's going to include carcinoma that comes from degenerated mucinous cyst, or occasionally there are rare variants of neuroendocrine tumors that have cystic components. And so that's another potential malignant neuroendocrine cyst. So just to start out with the pancreatitis associated cyst, Dr. Thakkar is going to go into a little more detail on these later, but in terms of agreeing on common terminology, this comes from the Atlanta classification, which helped to kind of clarify how we talk about these collections. And so we break these down into acute peripancreatic fluid collections, which are in the setting of no pancreatic necrosis. They generally occur within 4 weeks, and there's no definable wall. After 4 weeks, we now have a well-defined wall, again in the setting of no necrosis. And when necrosis is present, less than 4 weeks, this becomes an acute necrotic collection, and greater than 4 weeks becomes walled off necrosis. And so this gives us some common language to talk about these collections. And obviously in the clinical scenario, these are typically occurring during episodes of acute or recurrent pancreatitis.
So to start, in regards to the radiographic appearance of pancreatic pseudocysts, as Dr. Boone had mentioned, by far, these are the most common cystic lesions of the pancreas that we're going to encounter. They can be found anywhere along the length of the pancreas, as well as in the peripancreatic tissues, and even in some cases in adjacent structures and viscera. By CT imaging, pseudocysts are generally going to be unilocular, of low density or fluid density by CT, and their wall thickness can be variable depending on their state of maturity. By MRI, the appearance can be a little bit more variable, specifically with T1 weighted imaging, whereas some of these pseudocysts will appear T1 hyper intense due to either proteinaceous fluid or hemorrhagic components within the collection. Regardless, a pseudocyst should have an enhancing wall by both CT and MRI, but they should never have a central enhancing component or an enhancing mural nodule in association. And so here are some CT images from a classic appearance of a pancreatic pseudocyst, where we can see first and foremost, there is some residual stranding along the pancreas, which we've included here to indicate a recent episode of pancreatitis. And then in association, we have this very well circumscribed fluid density cystic lesion at the level of the pancreatic neck, which is a classic appearance for a pseudocyst as a sequela of recent pancreatitis.
So when we think about pancreatic serous cystadenomas, these are benign cystic lesions that are most common around 50 years of age. They tend to be asymptomatic. It would be very rare to have jaundice associated with these type of cysts. And in contrast to the pseudocyst, generally these occur in the setting of no history of pancreatitis.
And so to touch on the radiographic appearance of pancreatic serous cystadenomas, the majority are going to be found in the body or tail. And the classic presentation is a microcystic imaging appearance where the mass is composed of multiple small cystic components. And there is a rare variation where we can see a macrocystic growth pattern by imaging. And that can be a little bit of a diagnostic challenge to distinguish from a mucinous cystic neoplasm, which we'll discuss here shortly. But classically, by CT, serous cystadenomas are well circumscribed, low density. The internal septations tend to have enhancement with them. And very commonly with CT, we will have a central starburst calcification in association with a central scar or fibrous tissue. By MRI, these masses are generally of increased T2 signal, although their T2 signal is not as bright as simple fluid due to the microcystic nature of them. The scar that we see very frequently with these masses tends to be hypointense on T2 weighted imaging because of its fibrous content. And then that same scar generally will show delayed enhancement. And so here is a classic appearance of a pancreatic serous cystadenoma by CT imaging, where we have this well circumscribed mass in the head and uncinate. And as we can see there with the arrows, we have this central starburst or sunburst calcification, which is the classic appearance. And here's just the same patient, but corresponding MRI imaging. On the left-hand side of the screen is the T2 weighted imaging, where we see the microcystic growth pattern, where we have increased T2 signal, but you notice it's not quite as bright as the adjacent gallbladder, which contains more simple fluid. The central scar is of low T2 signal. And on the right-hand image, this is a post-contrast image where we can see that the mass, the majority of it is hypoenhancing, but the central scarring is of delayed enhancement.
So with mucinous cystic neoplasms, these are going to be essentially pre-malignant lesions, and they're most common, again, around 50 years of age, but have a significant female predominance, anywhere from 4:1 to 10:1 female to male ratio. And typically, these are also going to be asymptomatic, but occasionally they can enlarge significantly enough to cause symptoms from a mass effect. Pathologically, they tend to have a fibrous capsule. They don't communicate with the pancreatic duct, and their kind of hallmark finding is spindle cell ovarian stroma. So these can be associated with invasive cancer. And so as a result, we tend to recommend resection for these patients. And this is one category that can be difficult to differentiate from other cystic neoplasms like IPMN. And so this clinical scenario will often kind of guide us as to what we're thinking as we start the workup. And the management may be different if it's an IPMN that, you know, might not otherwise warrant resection, as we'll talk about later. So this clinical scenario is important as we consider these cystic lesions.
When it comes to the radiographic appearance of mucinous cystic neoplasms, similar to the serous cystadenoma we just discussed, the majority are located in the body or tail of the pancreas. However, they are different from the serous cystadenoma in that they are generally macrocystic. You can find a few internal septations, but microcystic appearance would be uncommon with a mucinous cystic neoplasm. By CT, they're going to be, again, low density, fluid density by the Hounsfield units. And one of the features that can be very helpful is peripheral calcification, which we see in about 15% of cases. By MRI, mucinous cystic neoplasms will generally follow the signal of simple fluid. So they'll be T2 hyperintense while T1 hypointense. The wall tends to be thick and enhancing, as Dr. Boone mentioned, and that corresponds with the fibrous capsule. But the important thing to delineate is that it does not communicate with the pancreatic duct by MRCP. And so here are some classic CT and MRI imaging from a mucinous cystic neoplasm in a young woman, where we have this well circumscribed cystic mass in the pancreatic tail. You can see on the CT and MR there's a thin internal septation, but the overall pattern is a macrocystic pattern that follows fluid density as well as signal intensity on both CT and MRI. The bottom right-hand image is a post-contrast image where we can see there is that capsule around the margins of this lesion, which corresponds to the fibrous capsule.
So for IPMN, this is going to make up a much more common portion of the patients that we see in terms of surgery, accounting for up to a quarter of the pancreatic resections that are performed at the larger volume centers. Typically, these are going to be found in older patients with an average of about 65, in contrast to the MCN that's more common around 50. Also, distinguishing this from an MCN is the male predominance. And symptoms in patients with IPMNs like jaundice or pancreatitis are more concerning for cancer.
So when it comes to the radiographic appearance of IPMNs, we have a variable number of presentations that I'll discuss here briefly. You can see we have 4 different scenarios to represent some of the different growth patterns we encounter. In the top left-hand corner, we have a typical side branch IPMN, which is involving only one of the ductal side branches, but not involving the main duct. And by MRCP, we can see this multiseptated, but otherwise cystic mass that clearly communicates with the main duct. As we move on to the top right-hand image, we can see this is a variation of a main duct IPMN with segmental involvement of the duct with otherwise no associated obstruction. Moving then to the bottom left-hand image, we have, again, a main duct IPMN rather than the segmental version. It is just diffuse dilation of the duct and filled with mucin. And then finally, in the bottom right-hand corner, we have a mixed type pattern, which shows us features of both a main duct and a side branch IPMN. So some of the other important things when we're reviewing these cases is, to assess an IPMN for features that are either worrisome or high-risk stigmata for high-grade dysplasia or malignancy. Worrisome features have been described as a cyst greater than 3 centimeters, a non-enhancing mural nodule, thickened or enhancing walls or internal septations, and a main pancreatic duct caliber of at least 7 millimeters. Whereas even more concerning would be the high-risk stigmata, which is one of these lesions in association with obstructive jaundice, an enhancing solid component seen by imaging, or the main pancreatic duct being 10 millimeters or greater in dilation. And so here's a few slices on the same patient from an IPMN, where we can see that on these contiguous slices, we have this abnormal pronounced dilation of the main duct in the body and tail, as well as some other areas where it looks like we've got some side duct involvement with some thin internal septation. Here we have a classic example of a side branch IPMN. Most commonly, these are described to be and found in the uncinate process, although we can find them elsewhere in the pancreas. But on the right-hand image, we have a thin section T2 weighted image, which shows that there's this multiseptated cystic mass in the uncinate, and we can see it communicating clearly there with the main duct in the pancreatic head. And the right or the left-sided image is a post-contrast image where we can even see there's a little bit of enhancement in some of these internal septations.
So just to briefly review the clinical presentation, MCNs tend to be more common in younger patients compared to IPMNs, more common in females. Their clinical presentation is similar, but we worry more about pancreatitis in the IPMN patients as a symptom concerning for dysplasia or malignancy. On imaging characteristics, peripheral calcifications can kind of distinguish MCNs. And then in terms of location, MCNs are going to be more common in the body and tail, whereas IPMNs can occur diffusely. So Dr. Schmidt's going to go into a little more detail about when we become concerned about an IPMN in terms of considering surgical resection. But the worrisome features and high-risk stomata that Dr. Markovich mentioned are based on the Sendai criteria, which then were further revised into the Fukuoka guidelines in 2017. And so that really guides what we consider worrisome or high risk, and also guides our need for surgical intervention as well as the workup. And so we kind of break these down into when we want to investigate, when it's safe to watch, and then when we consider resection. And Dr. Schmidt will go into this in more detail in his talk. So I think in the interest of time, we're going to hold questions until the end of everyone's presentations. But we're happy to take more questions about this. And obviously, this is to serve as an introduction, and we're going to go into a lot more detail with each of these in our subsequent speakers. So I'll turn things back over to Dr. Singh now, who's going to give us an overview on endoscopic ultrasonography.
I'll be going over the role of EUS in cystic lesion of the pancreas. So before I talk about EUS, I also briefly want to mention about clinical importance of clinical history. Patients with pancreatic cyst with a jaundice or recent onset of diabetes is going to be high risk to develop pancreatic cancer. Personal history or family history can also suggest risk of pancreatic cancer. So I think it's important to take a detailed history and family history with these patients. Now, I think Dr. Markovich did go into detail about the imaging criteria for cyst, but I think really so some of these cysts, even after high quality MRIs and CT scan, the key question remains, what type of cyst is this? Is this a mucinous cyst or a non-mucinous cyst? Is this cyst malignant? Is there a risk of progression to malignancy? Is this a pseudocyst? And if this is a pseudocyst, can it be drained? So here, EUS is an important tool in diagnosis and risk stratification. And also the role of EUS is also evolving in therapeutics. So because of the close proximity of the stomach to pancreas, we can examine the pancreas, the body and the tail of the pancreas from the stomach, while the head of the pancreas can be examined from the duodenum. We can get high quality real-time images of these pancreatic cysts, location, size, septations, thickness, if there is a presence of mural nodule, if main duct is dilated, if there is a mural nodule, or communication with the main duct. These all morphological features can be examined with an EUS. On this slide, you'll see this is an endoscopic image with a side viewing scope. You can see a fish mouth ampulla with mucin protruding. This can be seen in many patients with IPMN. This center image is an EUS image of a dilated pancreatic duct, and you can also see some dilation of the side branches, while an image in the right-hand corner is a dilated main pancreatic duct, and we can see a mural nodule. Now you can see EUS can provide really high quality images of these lesions. Mucinous cystic lesions. So this is a septated multilocular cyst. In the center, you can see these septations. This in the center is a mucinous cyst with a mucin wall in the cyst, while on this image in the right hand side, you can see there is a significant solid component which can harbor malignancy, and this is a very high risk for cancer. Serous cyst adenomas are easy to diagnose on imaging. They have specific EUS characteristics. This is a microcystic serous cyst adenoma with a honeycomb appearance. There are multiple tiny cysts that gives an almost solid appearance. There you can see anechoic cyst. These are thin-walled, multiple small cysts consistent with a serous cyst adenoma. Pseudocyst, Dr. Thakkar is going to go in detail, but we can examine pseudocyst and drain the pseudocyst with the use of an EUS. Now, for a non-endosonographer, all these most EUS images looks like black and white, but how does experienced endosonographer do just with morphological features? So diagnostic accuracy is varied in in many studies and can range from 40 to 90%. There is one large prospective multi-center study that found that just based on the US morphological features, um, the diagnostic accuracy of these lesions was only 51%. Therefore, what we do, this is a video you see of a fine needle aspiration. So what we do is basically we stick these cysts and collect some cyst fluid for analysis. FNA cytology tumor marker, and I think the game changer is the recently available molecular markers which have increased diagnostic accuracy. There is a recent meta-analysis which looked into KRAS and GNAS mutations for IPMNs and MCNs, and all diagnostic accuracy, even sensitivity, specificity for IPMNs was more than 90%. There are additional tools which we use to increase the diagnostic accuracy. So we have these biopsy needles. These are very small, tiny biopsy needles that can go through a 19 gauge needle and biopsy the cyst wall. Cyst wall biopsy has shown to increase the yield by around 30%. Then we have an echo brush. This is a brush which can increase the cytological yield. While I was in Pittsburgh and with Dr. Thakkar, we did a randomized controlled trial, and we did see there was an increase in the cytological yield from this echo brush. There is a contrast enhanced EUS as well, basically injecting contrast. So will show that most of the mural nodule or the solid component will have a blood supply and will enhance as compared to a mucin or a debris which is not gone, which will not enhance when enhanced with contrast. EUS-based needle confocal laser endomicroscopy is also evolving, and this there's a small imaging probe which again goes to a 19 gauge needle, can be put on the cyst wall, and it provides images of the cyst wall. So in this image you say, see, this is a vascular pattern typical for serous cyst adenoma, and these finger-like projections can be seen in patients with IPM. And these are very, if you get the images, these are very specific. Sensitivity can range from 70 to 90%. So I think we already went over the high risk features or the worrisome features, as we always look for them. And I think we are talking again and again after about these is because many of our decisions are based on these size of the cyst. But I think size of the cyst is a criteria, but even a smaller size does not exclude malignancy. So I think that's one important point. Dilated pancreatic duct presence of a mural nodule or a solid division. I think one important thing is how to differentiate on an EUS between a mural nodule or a mucin wall. So these are EUS images. So if you see this on the left-hand side, this is a mucin ball. You can see this is a round, well demarcated outer edge, and the rim is hyperechoic, whereas the center is hypoechoic. So this is a mucin ball. As I shown in the video, that the mucin wall will move with FNA or with patient position. Whereas if you see these right side images, these are mural nodules. These are isoechoic or hypoechoic and are similar to that just in soft tissue. These do not have a smooth edge or does not have a hyperechoic rim. And on a contrast and hence you can see many of them can have vascular supply.
Recently, many advances have been made in US-guided therapeutics. US-guided ablation of pancreas cyst is a minimally invasive treatment option, especially for patients who are not surgical candidates. It avoids systemic toxicity of these chemotherapeutic agents and provides high concentration of chemotherapy drugs locally within the cyst. US guided cyst ablation has now evolved from alcohol ablation to a combination of paclitaxel and alcohol, and now alcohol free chemoablation using a mixture of paclitaxel and gemcitabine. Recent randomized controlled trial showed that alcohol-free chemoablation is safer and effective for pancreas cyst ablation. The adverse events are mostly related to alcohol use and can be avoided with alcohol-free ablation. Radiofrequency ablation has of pancreatic cyst has also been reported. However, the data is limited, and the role of US RFA continues to evolve. Thank you, everyone. Next, we have Dr. Stell Patadji. She'll be talking about the role of cytology and ancillary studies in diagnosis of pancreas cyst.
My name is Dr. Patadji. I'm a pathologist. I am here to give, with our main goal being to differentiate mucinous from non-mucinous cyst. The cytological criteria for mucinous cyst
Dr.
are either
Patadji,
mucin
you need
production,
to switch. You go to display setting up in
low
the
or
right
high
corner.
or
Yeah, and swap presenter. Yeah.
elevated CEA levels, or characteristic genetic abnormality such as KRAS and GNAS mutation seen in pancreatic mucinous cyst. CEA and amylase are helpful in this triage. Although a CEA level of less than 5 nanogram per milliliters implies a low risk of mucinous cyst, a level greater or equal to 200 nanogram per milliliters is very suggestive but not diagnostic of a mucinous cyst. Because levels above 192 nanogram milliliters are only 80% accurate. On the other hand, low and high levels of amylase can be seen in mucinous cyst. Further classification of pancreatic cyst can be done through molecular studies by looking at characteristic abnormalities. VHL mutations are seen in serous cystadenomas. Beta-catenin mutation are seen in solid pseudocapillary neoplasm. Mucinous cystic neoplasm can have mutation in either the KRAS or RNF43 genes. Low-grade IPMN can have mutations in either KRAS and or GNAS or RNF43 genes. Presence of additional mutation in the CDKN2A or PTEN, SMAD4, P53, AKT1, and PIK3CA genes in an IPMN with already KRAS and or GNAS mutations are highly sensitive and specific for IPMN with high-grade atypia or invasive carcinoma. Immunohistochemical stains are available for the underlying genes and can be performed on the cell block. Moving on to the reporting. Our first case is that of a 41-year-old male with recurrent acute pancreatitis and pancreatic tail pseudocysts. We received 40 milliliters of cloudy pink fluid. The cytospin shows many macrophages in a background of debris and abundant blood. These findings were negative for malignant cells and consistent with a pseudocyst supported by the low CEA and high amylase level. Case 2 is that of an 80-year-old male with a history of colon cancer, alcohol abuse, and a CT finding of a pancreatic cyst. We received 3 milliliters of thick and mucinous fluid. The smears were hypocellular but showed thick colloid-like mucin with bland columnar cells. These findings were positive for neoplasm, mucinous cyst fluid with low-grade atypia. The high CEA and amylase level, in addition to the GNAS mutation, are in keeping with a low-grade IPMN. Case 3 is that of a 60-year-old male with an incidental pancreatic cyst. We received 3 milliliters of cloudy red fluid. The cytospin showed three-dimensional large groups of ductal cells with abundant cytoplasmic mucin and irregular nuclear membrane in a background of abundant debris. The smears from the mural nodule showed similar finding with evidence of extracellular mucin on the lower right corner of the diff quick smear in A. On the cell block, P53 and SMAD4 were aberrant, suggestive of mutation in those genes. These findings were positive for malignant cells and consistent with invasive adenocarcinoma. The CEA was highly elevated compared to the amylase level. My last case is that of a 51-year-old male with a father who died of pancreatic cancer. He presented with an incidental pancreatic tail mass on CT. Outside cytology was atypical with molecular abnormalities in the KRAS, GNAS, and P53 genes. The patient underwent a distal pancreatectomy and splenectomy. The surgical resection specimen demonstrates a dilated main pancreatic duct in the middle of the picture. These are high-power images with A showing a cyst wall lined with low-grade dysplasia, below which is invasive adenocarcinoma. B shows a nice transition from top low-grade to high-grade dysplasia, and C showing a high-power image of the low-grade dysplasia, and D showing a high-power image of a high-grade dysplasia with prominent mitosis on the right upper hand corner. The final diagnosis showed an invasive, moderately differentiated adenocarcinoma arising in association with IPMN. Thank you for your attention, and here are my references. We will now move on to surgical management and use of robotics by Dr. Schmidt and Dr. Boone.
Thanks, everyone. I'm Carl Schmidt. I'm one of the hepatobiliary surgeons and surgical oncologists here at WVU. I have a case presentation, and then we'll go over some of the surgical principles in terms of our management of pancreatic cystic lesions, namely the mucinous cystic lesions. So I have a case of a 41-year-old woman who experienced a muscle strain and some back pain during a event of helping move some furniture. This was severe enough that she went to the local emergency department, where CT scan somewhat incidentally found a pancreas body cystic lesion. She did, interestingly, have some fluid and some stranding around the lesion, though otherwise did not have labs consistent with pancreatitis, but there's certainly, with the acute pain and this finding, there was a question of pancreatitis. This was further supported by her initial local endoscopic ultrasound, in which some tan fluid was aspirated that seemed more consistent with a pseudocyst, as it did not appear mucinous. And she had a Pancreatic study with no mutations found in the fluid. So she was referred to me with a concern for, should this still yet be managed surgically, given her young age and health, and as others have eloquently described, the uncertainty we have with diagnosis of these lesions. So as we do, I got the team together and we talked about options for her, and certainly we thought she had still a broad differential diagnosis of asymptomatic pancreatitis with a pseudocyst, a lymphangioma, lymphangioepithelial cyst, IPMN, MCN, lots of things on the differential. Ultimately, I came to talk with her again, and we settled on a plan of short interval surveillance and did another MRI after about 3 months, first and foremost to see if the cyst fluid would reaccumulate. And it did reaccumulate, and the cyst continued to measure about 5 centimeters in size. So although she was asymptomatic at that time, because she really had no risk factors for pancreatitis that we could determine, we all weren't willing to ultimately believe that she had a pseudocyst and otherwise one-time or asymptomatic pancreatitis. So we sent her for a second endoscopic ultrasound, which again confirmed a 5 millimeter cyst an 8 mm possible solid component. This time the fluid was sent for CEA and amylase, which showed a low amylase but a high CEA. And interestingly, repeat genetic analysis showed a KRAS mutation in the cyst fluid, now concerning, as you know, for a different diagnosis. So in terms of what we should do, I'm sure you all can imagine, since I'm the surgical presenter, we took her to the operating room for a robotic distal pancreatectomy for this pretty large cystic lesion that fortunately did not have any other concerning intraoperative findings, no invasion of local structures or no other tumors or anything. And the final pathology did confirm an MCN with low-grade dysplasia, but no high-grade dysplasia, no carcinoma in situ. So, so fortunately for her, I think this was still caught, obviously, at the pre-malignant phase. So when we talk about our surgical goals for these mucinous lesions and cystic lesions of the pancreas, it's maybe first to quickly go over what are the surgical goals if we have a cancer, and those are clear to everyone: a margin negative resection, remove enough lymph nodes, safe operation without hemorrhage or injury to surrounding structures, minimize our postoperative complications like leak. And the critical steps of these operations are the same regardless of whether we're open, robotic, or laparoscopic. If we think about these same goals in patients with pancreacystic lesions, well, all of those goals remain important if ultimately that cystic lesion has a cancer. So as you can imagine, we conduct a lot of these pancreatic resections as if that cystic lesion is a solid tumor. The operations are not really that different at all. We want the margin to be clear of concerns like high-grade dysplasia. We do not want to rupture the cyst, just like we would not want to violate the capsule of a tumor. Areas of controversy, as others have mentioned, continue to be what are our exact indications for resection, what is the extent of resection for main duct IPMN, and there are some emerging non-operative therapies for cystic lesions, so I'm not sure we're discussing, but that may be another interesting topic to go over in a subsequent gut club that my advanced endoscopy colleagues, I think, have some really exciting things on the horizon. When to resect an IPMN, I'll point to these Fukuoka guidelines that Dr. Boone mentioned, and I'll just highlight, here are and this helps with, surveillance imaging, depending on features, helps one get started on which ones need more workup, which ones can be watched without further workup. But I've highlighted what for a surgeon would be signs to move to operation, particularly in healthy patients, without, even if there is more workup, but where we are already going to be concerned about there's cancer present in the cystic lesion now, and that's jaundice, dilated main pancreatic duct, especially if that seems more like obstruction and not a main duct component. Certainly caliber, again, that's caliber change of the main duct with gland atrophy, lymphadenopathy, elevated CA19-9. Those are kind of hard signs, enhancing mural nodule, things concerning for cancer now, positive cytology rather than waiting. Some other things, maybe not hard signs, but still concerning, rapid growth rate, those types of things will get us to the operating room fairly quickly. What are the outcomes? This is one of the series. It's getting a little long in the tooth now from Hopkins, but 136 people, the majority were Whipples, some totals, probably for diffuse main duct involvement. In this series, again, though, we have to do these operations in the higher risk looking cystic lesions like there may be a cancer now, because there may be even an up to close to 40%. And then the cancer operations can still have half of patients with lymph nodes, too many with positive margins. So these are difficult operations. Either way, we must make sure we have achieved the goals of margin negativity if we can, and all the others I mentioned. In those who had residual IPMN at the neck or unsnate margin in this series, that was about a quarter of the patients. And so we don't always remove all of the pre-malignant features, arguing for continued surveillance in those patients even after operation. In those without an invasive component, 3 out of 4 survived for 5 years. Interestingly, some of these people died from metachronous other cancers. 43% of people with an invasive cancer survived 5 years. So not surprisingly, many people with pancreas cancer after resection are not cured. So in summary, these cystic lesions are a diagnostic challenge, as others have said. Pancreas cancer is rarely cured, so we must get it right when we have the chance to do a preventive operation. And we do it here at WVU just like at other places by teamwork. As you've seen, we've got all these great people and others that work with us to help us hopefully do the right things. So with that, I'll turn it over to Dr. Tucker for the last talk.
Thank you, Carl. Can everyone hear me okay? Okay, great. It's my pleasure to share with you the passion that we have here at WVU Medicine over the management of pancreatic fluid collections. I would encourage, we've seen some questions come in through the chat box. Please continue to send them in and our faculty will answer them as we go. So as most of you are aware, pancreatitis is one of the leading causes of hospital-related admissions in the United States. Inpatient costs exceed $2.5 billion US, and pancreatic necrosis occurs as a consequence of severe acute pancreatitis in approximately 15% of patients. Without intervention, infected pancreatic necrosis can oftentimes progress to death. Now, when severe acute pancreatitis happens, it usually develops into an interstitial pancreatitis, but can also develop into a necrotizing pancreatitis. Early on, this can have collections known as an acute fluid collection or an acute necrotic collection. And as these collections mature, we develop into pseudocysts or walled off necrosis. Here you can see some images related to pancreatitis and necrotizing pancreatitis. Specifically, on the left-hand side in the upper image, you see an enhancing pancreas with fluid around it consistent with an acute fluid collection. As that matures, in the bottom left-hand image, you see an example of a pseudocyst. In the upper hand image, you can see an unenhancing pancreas with some fluid and necrotic debris there that the arrows are pointing out, consistent with an acute necrotic collection. And in the bottom right-hand image, you can see evidence that that has now walled off into a walled off necrosis. Now, what are the indications for intervention? Not all collections need to be intervened upon, but those that cause symptoms do. This includes gastric outlet obstruction, nausea, vomiting, persistent pain, or infectious type symptoms related to pancreatic sepsis. And when it comes to intervention, we have different methods that are available to us. Amongst them is the transmural drainage, and you'll see an example of that here in this video with percutaneous drainage, transpapillary drainage, and surgery. And here you can see in the video how we obtain access using a EUS-guided transmural drainage approach, where we can identify that pseudocyst, place a needle within it, and then coil a wire, and thereby then perform our interventions to drain that pseudocyst simply by dilating a tract and then ultimately placing double pigtail stents across to allow it to drain. Now, the choice of technique really depends upon the local expertise. The collections that abut the stomach and duodenum generally are best managed with an endoscopic approach. As you've heard, we have a multidisciplinary approach here at WVU Medicine, where every week the surgeons, the interventional radiologists, the radiologists, and gastroenterologists all come together to talk about really what's the best management strategy for the patient or with a patient with these complex fluid collections. And here you can see how those stents are deployed. Now, when it comes to EUS-guided transmural drainage versus surgery, Bang and colleagues did a nice study where they looked at procedural duration, disease-related adverse events, SIRS, length of ICU stay, and mean total costs in the EUS group versus a surgical group in a prospective randomized fashion. And what they were able to demonstrate was in all these primary endpoints that EUS-guided access and drainage performed superiorly as compared to surgery. And as such, when feasible, we really try to optimize an endoscopic approach should the expertise and the ability to perform the intervention be applicable in these fluid collections. And so what about transmural drainage versus capillary drainage? Well, as we said, EUS is really the standard of care for transmural drainage because we can better visualize in vasculature, and we can also deploy larger caliber stents as shown in this animation, where you can see a distal flange is deployed under sonographic guidance, and a proximal flange is deployed under endoscopic guidance. This can allow for larger caliber interventions into these cavities. Now, for smaller collections that communicate with the main pancreatic duct, transpapillary drainage may be beneficial. And here's just an example of a patient with hereditary pancreatitis and acute recurrent pancreatitis in whom we performed ERCP. And on pancreatogram, what you can see here is The pseudocyst is in communication with the main pancreatic duct, and as we continue to inject, we can opacify an upstream pancreatic duct. We can then send a wire deep into that upstream duct and ultimately place a stent to allow this stricture and pseudocyst to heal and ultimately treat the episodes of acute recurrent pancreatitis. This patient did great. His pancreatitis episodes resolved, and he's done well since. Now, what about timing of intervention? Well, there's a lot of controversy as to whether we should intervene when we should intervene on these patients. The international guidelines suggest postponing intervention till at least or approximately 4 weeks. This study done by the Minnesota group, they were able to demonstrate was that in those patients in whom that were intervened on early, less than 4 weeks, they were able to demonstrate that there was no difference in procedure-related complications in this early approach. Now, there was some increased hospital stay and ICU stay, but this by nature was likely related to these patients being sicker, which required an earlier intervention. In essence, I think this needs to really be taken on a case-by-case basis. If there's evidence of a wall or a partial wall and in a multidisciplinary approach, the discussion looks like it's best to approach these patients. That timing is more of the secondary issue, and whether the presence of or absence of a wall is more of the primary issue. And so what about plastic versus metal? What are the considerations? Well, certainly you can see here there are many considerations that go into effect when we approach these from an advanced endoscopy standpoint. In general, plastic stents offer us certain advantages, including flexibility, easy removability, but of course have their disadvantages. And then metal stents also offer advantages, including they have a larger lumen, and so you can avoid an aggressive dilation. And they, of course, have their own disadvantages. When we look at the data comparing plastic to metal stents, what we see here is, in general, metal stents seem to perform superiorly compared to plastic stents, with better clinical success and lower adverse event. Here you can see in the video a wall area walled-off necrosis that's abutting the stomach. And on endoscopic evaluation, what we see here is the cavity actually putting pressure on that gastric lumen. Once it's actually, the tract is dilated, you can see pus and debris coming out. And once the metal stent is deployed, you can see that larger caliber stent as compared to the previous video I showed you. There's really a rapid decompression of this septic material from the pancreas, from the pancreatitis. Now, what we can also do is place double pigtail stents to anchor these stents into place so as to minimize the risk of migration. Well, what about fully covered stents versus lumen-opposing metal stents and double pigtail stents? You know, in this retrospective analysis where they looked at the 3 arms, what they were able to demonstrate was double pigtail stents had a lower predictor of success, and the use of lumen-opposing metal stents had actually lower number of sessions for walled-off necrosis resolution. And this is primarily because we can introduce endoscopes across these lumen-opposing metal stents and perform necrosectomies as you're seeing in the video on the right. There you can see the example of necrotic debris that we can oftentimes encounter, and then using snares or nets or rat type devices, we can aggressively debride these collections so as to ultimately get to this end point of healthy pink walls that are with a cavity that's cleared out that then can collapse spontaneously. Beck and colleagues actually did a very nice prospective randomized study looking at lumen-opposing metal stents versus plastic stents. And interestingly enough, what they demonstrated was not a significant difference in clinical outcomes, but actually they found that there was an increased adverse events in the lumen-opposing metal stents that somewhat confused the picture. But when they made a change in protocol, there was no difference in this outcome. And what they found was that this was in several cases due to interlacing blood vessels that got embedded into the distal flange of the stent. And as such, you know, it's been a protocol at WVU Medicine to always, whenever we place lumen-opposing metal stents, to always place double pigtail stents through these stents so as to prevent this type of complication from happening. Also, these complications were seen within 5 weeks. So we always image our patients at 4 weeks and remove these stents at 5 weeks because the risks seem to go up after 5 weeks for this in their protocol. And so once we find this, we again image at 4 weeks. If there's evidence that the cavities collapse, and we remove stents at 5 weeks. One last point to touch base on is the role of proton pump inhibitors. In this multi-center retrospective analysis, what they looked at was the use and absence of PPI in the need for repeat necrosectomies. And what they were able to demonstrate was that the use of PPIs actually retarded the rate of dissolution of solid necrotic debris, such that these patients oftentimes required more necrosectomies as compared to the group that was not on PPIs. And as such, it's also our protocol to hold proton pump inhibitors these patients to allow the acid to get into these cavities to really help with some of the physiologic debridement that can occur. And interestingly, there was no difference in bleeding or ulceration in this study. So in summary, pancreatic fluid collection may occur as a sequelae of pancreatitis. The need for intervention should be determined by symptoms and always undergo multidisciplinary collaboration. Timing of intervention really remains controversial, but evidence suggests that early intervention may be performed in those that cannot be delayed. US transmural drainage is the most advantageous approach when feasible, and the type of stent placement continues to evolve with shorter and likely less necrosectomies with lumen-opposing metal stents, and the ideal medical approach continues to be delineated with perhaps holding PPIs being of benefit. So at this point, I'll thank you all for your time, and we'll pause for any questions.
So one of the questions directed to Dr. Thakkar. So necrosectomies usually require multiple sessions, are challenging. So what are the newer devices or techniques that are available to kind of clean these pseudocysts out?
Yes, that's a great question. There's been a lot of advancement in this area. One of the problems with intervening on these walled-off necrosis is you're in free space, and with endoscopy, you're always working kind of at a single luminal point of view, so you lose traction and counter traction. But there's these endorotor devices that we've been using here at WVU Medicine that allows us to debride these cavities a little better. They're also developing a larger type endorotor device that can still fit through the scope and allow us to perform more aggressive debridement so as to clean these cavities out better. We tend to use a lot of snare and rat tooths as well that work well in debriding these.
Another question I have it's for Dr. Markovich. So we see all these cysts are usually incidentally detected. So as referring providers or GI doctors or surgeon, can you tell us the difference between CT and MRI for evaluation of the pancreatic cyst? And is the CT or MRI superior to CT scan in evaluation of these cysts?
Yeah, absolutely. And so from our perspective, MRI offers a number of huge advantages when assessing cystic masses of the pancreas, because MRI has a superior contrast resolution between soft tissue and fluid. And since many of these masses are of fluid signal or fluid content in some way, shape, or form, they generally do a much better job of not only delineating these masses, but also detecting cases where there are multifocal masses, such as in IPMNs, which we see quite commonly. Many of these smaller masses might not be picked up on CT. The other thing is with MRI, we have some other options in terms of some of our post-processing techniques and different sequences available to us to help us characterize lesions. In particular with CT, sometimes a mucin globule versus a true soft tissue mural nodule can be difficult because they can have a similar density by CT, whereas with MRI, either differences in signal intensity or being able to use subtraction post-contrast imaging can help us delineate whether there is true enhancement and therefore solid components in these. So from our end, MRI is certainly the preferred study in those patients that are able to get it.
Thank you, Dr. Markovich. One question I have for Dr. Patadji is, molecular markers are definitely very helpful in diagnosis. So how can we perform them? And are these available at all centers?
Yeah, thank you for that question, Dr. Singh. Obviously, molecular markers are not readily available. These are generally next generation sequencing, generally available at large laboratories and also big academic centers. And I think another driving force behind that is the multidisciplinary approach to these pancreatic cysts, where you have to have expertise in endoscopy, surgical management, really, for those hospitals to be able to carry all the management through. So, but these are very limited, and as molecular is still evolving, it's a pretty much a lab-based test. And the difficulty about that is also multiple labs have different platforms, and they are all different. So it really depends on where you're sending your testing and what platform they're using. Some still have Sanger sequencing, which is a bit different. It has a lower sensitivity and specificity for mucinous cyst versus next generation sequencing. So there's just multiple variable, but it's not readily available everywhere.
So
there was one more question, it looks like, that came through the chat regarding a role for surgery in the management of necrotizing pancreatitis. And I think Dr. Tucker is still having some technical issues, so I'll take the first shot at that one. I think for certain cysts or for certain walled off necrosis collections that are not juxtaposed to the stomach, it's a little bit more challenging sometimes to perform an EUS guided procedure. And so for collections that are more lateral, oftentimes we'll incorporate a step-up procedure where we'll start with a single percutaneous drain. If there's no clinical improvement, then we'll go to a second drain. And if the second drain still is kind of failing to resolve the issue and there's a persistent collection, then we'll perform a videoscopic retroperitoneal debridement, kind of using those drains as a guide to put ports in and go into the collection laparoscopically and perform a debridement that way, and then leave large drains in after that procedure. So we tend to favor with our, the skill set of our excellent advanced endoscopists to try to manage these endoscopically, but there are select patients who are not as amenable to it. And potentially also a role for, as we heard, sometimes the endoscopic necrosectomy can be kind of challenging to get the whole thing cleaned up. And so if after repeat procedures, there's some persistent necroma, then potentially a role for surgery there where you can get a little bit more aggressive debridement.
Yeah,
If Dr. Singh or Schmidt have anything to add there.
Yeah, I agree with Dr. Boone that, today most of the cyst or walled off necrosis we can manage with endoscopy, but definitely there is a role, especially some of the patients we see which are referred and are complicated cyst or walled off collections which are away or fail with endoscopic therapy. Then, we can use IR guided drain placement and step up therapy with the surgeon. So we run all the cases and basically try and figure out the appropriate way for every patient.
Well, I think we've run over our time. Thank you everyone for your involvement in this inaugural event. Thank you everyone for attending. Looking forward to doing this again in the future and look for notifications from us in the future. And thanks again.
Thank you.
Thank you.